You know, usually when we talk about a medical diagnosis, uh, there's this expectation of mechanical precision. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points at the glowing screen and says, well, there it is. There is the problem.
That's
Right.
comforting. I mean, we naturally want pathology to be visible, easily categorized into a binary state, broken or not broken, normal or abnormal.
But then you step into the world of the shoulder girdle, and suddenly that x-ray machine feels woefully inadequate. I mean, we're looking at a diagnostic landscape that is just incredibly murky.
Yeah, because so much of what goes wrong in the shoulder, it isn't a simple visible bone snap. It's a failure of the wiring.
Exactly. A failure of the wiring.
The shoulder is arguably the most complex joint complex in the human body. It sacrifices stability for this immense range of motion. And to achieve that, the bones are essentially floating.
Right.
The scapula, the collarbone, they are a mechanical scaffold hung on and entirely controlled by this incredibly dense web of nerves.
And that is exactly our mission for this deep dive. If you're listening to this, you might be driving, maybe you're doing chores, or you're heavily preparing for a high-stakes scenario like the FRCS trauma and orthopedics exam.
Which is incredibly stressful.
Oh, absolutely. And you are trying to absorb these complex 3D spatial relationships without the benefit of a textbook in front of you. So our core theme today is to stop thinking about the shoulder as just a collection of bones.
Yeah.
We have to map the electrical grid.
Because if you understand the electrical grid, you can work backward.
Right.
The golden rule for understanding shoulder pathology is that for every anatomical structure, you need to know exactly which nerve runs it. And crucially, what specific signature of winging or wasting appears when that nerve fails.
You see the physical effect in the clinic, and you immediately deduce the anatomical cause.
Exactly.
So to make sure this actually sticks, especially if you're staring at the bumper of the car in front of you right now, we are going to build this anatomy entirely with words. We'll paint the picture so clearly you won't need a diagram.
No visuals needed.
None. And because memory requires friction, we are going to ensure that every nerve, every ligament, and every crucial diagnostic discriminator is stated twice.
Twice. That's a great rule.
We'll also pause a couple of times to consolidate what we've built, do some rapid recaps, and ensure we distill each section down to its absolute core takeaway. You'll get an if you only remember one thing line at the end of every topic.
It requires rigor. But when you are sitting in an exam, or, more importantly, standing in an operating theater, every fact has to be correct. You have to be able to anticipate the anatomical traps before you fall into them.
Absolutely. So let's start with the most frequently tested structure in the shoulder, the one that always seems to pop up, the suprascapular nerve.
Ah, yes, a classic.
If we're mapping the wiring, where is the power plant? Where does this start?
So the origin point is the upper trunk of the brachial plexus in the neck.
Right in the neck.
Specifically, the suprascapular nerve branches off at a junction known as Erb's point. We're talking predominantly about the C5 nerve root, with some contribution from C6.
Okay, upper trunk, Erb's point, mainly C5.
From that origin in the neck, it heads outward and backward, making a direct line for the top edge of the shoulder blade, the scapula.
And it mitches the top of the scapula, and it hits its first geographical obstacle, right? Because the bone isn't perfectly flat across the top.
No, it's not. There's a divot, a groove carved right into it called the suprascapular notch.
The suprascapular notch.
And that notch is our first major anatomical checkpoint. It's not just an open groove, though. Stretching tightly across the top of this bony notch is a thick band of tissue called a transverse scapular ligament.
So you have a bony floor, the notch itself, and a ligamentous roof.
Exactly. This creates a very rigid, unyielding little tunnel.
But the suprascapular nerve doesn't travel down from the neck alone, does it? It's running alongside the suprascapular artery and vein. Do they all cram into that same tiny tunnel?
They do not. And this spatial relationship is a classic anatomical discriminator.
The exam loves this one.
They really do. So the suprascapular nerve passes deep. It goes under the transverse scapular ligament right through the bony notch. Meanwhile, the suprascapular artery and vein, they take the superficial route. They pass over the top of the transverse scapular ligament.
Let me make sure that's locked in, because I can easily see how that gets flipped in a high-pressure moment. So the suprascapular nerve passes deep under the transverse scapular ligament, and the suprascapular artery passes superficial over the ligament.
That's it. And there is a classic spoken mnemonic used in medical training to keep this straight.
Oh, I know this one.
Go for it.
It's Army over, Navy under.
Perfect. Army over, Navy under, artery over the ligament, nerve deep or under it.
Let's say that twice for the distracted drivers. Army over, Navy under, Artery over, nerve under. Okay, so the nerve makes it through that rigid tunnel. What is its destination?
I find it helpful to think of the suprascapular nerve as a train line with two distinct stations.
I like that analogy.
Stop 1 is immediately after it passes through that suprascapular notch. As soon as it exits the tunnel, it gives off branches to supply the supraspinatus muscle.
And the supraspinatus is sitting right there in the shallow ditch on top of the shoulder blade.
Exactly.
Its primary biomechanical job is to initiate the abduction of the arm, right? It gets the arm moving out to the side for the first 15 degrees before the massive deltoid muscle takes over.
That's stop 1. The suprascapular notch supplies the supraspinatus, but the main trunk of the nerve, it keeps moving.
It doesn't stop there?
No, it winds around the back of the scapula, navigating past the base of the scapular spine through another bony landmark. This one is called the sphenoglenoid notch.
Sphenoglenoid notch. So we've moved from the top of the shoulder blade down to the back of it.
Yes, the sphenoglenoid notch is stop 2. After passing this second notch, the nerve terminates by supplying the infraspinatus muscle.
The infraspinatus.
This muscle is a massive powerhouse sitting below the spine of the scapula, and it is responsible for external rotation, giving you the power to turn your arm outward against resistance.
Let me map that out again to be safe. We have a two-stop journey. Stop 1 is proximal at the suprascapular notch, where the nerve supplies the supraspinatus. Stop 2 is distal at the sphenoglenoid notch, where the nerve supplies the infraspinatus.
Now apply that anatomy to a clinical presentation. This two-stop train line creates a very specific localization puzzle for you to solve.
Okay, let's solve it.
If a patient has a lesion, like a physical crush or blockage, at stop the proximal suprascapular notch, what happens?
Well, if the tracks are blocked at the very first station, the train can't get anywhere. So a lesion at the proximal suprascapular notch knocks out both the supraspinatus and the infraspinatus muscle.
Exactly.
The whole line goes down. You'd see wasting on the top and the back of the shoulder blade, and the patient would be weak in both initiating abduction and external rotation.
But what if the lesion is located distally at stop 2?
If the blockage is at the sphenoglenoid notch, the train has already successfully dropped off its cargo at the first station. So the supraspinatus muscle is perfectly fine, but the signal never makes it to the final destination.
Right.
So a lesion at the distal sphenoglenoid notch spares the supraspinatus, and it hits only the infraspinatus.
That is the critical discriminator. Let's solidify it.
Yes, rule of 2.
A proximal lesion at the suprascapular notch takes out both supraspinatus and infraspinatus. A distal lesion at the sphenoglenoid notch spares supraspinatus and takes out only the infraspinatus.
So how does this actually walk into a clinic? I'm picturing an athlete.
It almost always is. The classic exam vignette is an overhead athlete, like a volleyball spiker or a baseball pitcher.
Lots of repetitive shoulder motion.
Exactly. They come in complaining of vague, deep shoulder ache and weakness. You ask them to take off their shirt, and you look at the back of their shoulder. The muscle belly below the spine of the scapula, the infraspinatus, is completely hollowed out and wasted away.
Oh.
Yeah. You test their strength, and they have profoundly weak external rotation. But when you check the top of the shoulder, the supraspinatus is full, and they can initiate abduction perfectly.
Isolated infraspinatus wasting. You see that, and you know instantly the blockage is at stop 2. It's a sphenoglenoid notch lesion.
Spot on.
But what is physically acting as the blockage? Why would the nerve suddenly get pinched way down there on the back of the shoulder?
This is where we bridge from nerve pathology to intra-articular joint pathology.
Oh.
The most common culprit for compressing the nerve at the sphenoglenoid notch is a ganglion cyst, a fluid-filled sac.
Okay, a cyst.
And these cysts do not just appear spontaneously out of healthy tissue. The highly tested association is that these cysts almost always arise from a SLAP lesion inside the shoulder joint.
A SLAP lesion, that stands for superior labrum anterior and posterior.
Right.
It's a tear in the cartilage ring, the labrum that surrounds the shoulder socket, right where the biceps tendon anchors into it.
Think about the biomechanics of a joint. The labrum acts like a rubber gasket, sealing the shoulder fluid inside. When you tear that superior labrum, the SLAP tear acts like a one-way valve.
A one-way valve for the fluid.
Exactly. Every time the athlete moves their shoulder, the massive pressure inside the joint forces synovial fluid out through that tiny labral tear.
And because it's a one-way valve, the fluid leaks out into the surrounding tissue, but it can't get back into the joint.
Right, so it pools, encapsulates, and it gradually expands into a balloon-like ganglion cyst.
And because of the surrounding fascial boundaries, where is the path of least resistance for that expanding cyst?
It expands directly into the spondylogonoid notch. It acts like a slowly inflating balloon, pressing the suprascapular nerve hard against the bone.
That is a fascinating chain of causality. An injury deep inside the joint at the cartilage ring acts as a microscopic pump, forcing fluid out to form a cyst, which acts like a boulder sitting on the train tracks at stop 2, paralyzing a muscle on the outside of the shoulder blade.
It's incredible. And it fundamentally changes the surgical approach.
How so?
Well, if you have an MRI showing a spondylogonoid cyst causing isolated intraspinatus wasting, you cannot just surgically remove the cyst.
Because the pump is still running.
Exactly. If you don't fix the underlying SLAP tear, the one-way valve is still open, and the cyst will simply refill. You have to fix the intra-articular leak to cure the extra-articular nerve compression.
That makes total sense. So if you are distracted right now, come back to this. Listen to me. If you only remember one thing from this segment, a proximal notch lesion takes out both supraspinatus and infraspinatus. A distal spondylogonoid lesion spares supraspinatus, hits only infraspinatus, and is intimately tied to a SLAP-related ganglion cyst.
Well said. Let's smoothly transition from the top of the scapula, where we just map the suprascapular nerve, and move entirely to the back of the shoulder. We are entering the territory of the named spaces.
Yeah, the named spaces, the quadrangular and triangular spaces.
Yes. This is prime anatomical testing ground because it requires absolute, rigid spatial memorization.
The exam clearly loves pairing these specific geometric spaces with the neurovascular structures that pass through them. We're talking about the quadrangular space, the triangular space, and the triangular interval. To understand them, we have to build the borders first.
Right.
Paint the architecture of the back of the shoulder for us.
Imagine you are standing behind a patient looking at their right shoulder. We're going to build a grid.
Okay, building a grid.
First, we have two horizontal muscles running across from the shoulder blade to the arm bone. On top is the teres minor.
Teres minor on top.
Below it, running parallel, is the teres major. These two muscles form the horizontal roof and floor for our spaces.
I'm picturing it, teres minor above, teres major below.
Now we need vertical pillars to intersect them. Dropping straight down from the scapula, intersecting those horizontal muscles, is the long head of the triceps muscle.
Long head of triceps. Got it.
And on the far outside edge, forming the lateral boundary of the whole complex, is the humerus bone itself.
Okay, we have our grid. Let me repeat it. Teres minor above, teres major below, the triceps muscle dropping down vertically, and the humerus bone on the far outside. Let's start with the most important one, the space that causes the most clinical trouble. The quadrangular space.
The quadrangular space is exactly what it sounds like, a four-sided square. Let's trace its borders on our grid.
Let's do it.
The top border is the teres minor. The bottom border is the teres major. The medial border, the side closer to the midline of the body, is the long head of the triceps. And the lateral border, the outside edge, is the surgical neck of the humerus.
And what vital structures are traveling through this four-sided square?
The quadrangular space carries two critical structures passing from the front of the shoulder to the back.
Which are?
The axillary nerve and the posterior humeral circumflex artery.
Let me state that again to lock the pairing. The quadrangular space is bordered by the teres minor above, the teres major below, the long head of triceps medial, and the humerus lateral. Its contents are the axillary nerve and the posterior humeral circumflex artery.
Perfect. Now, just medial to that square, closer to the spine, the grid creates a three-sided opening. This is the triangular space.
Triangular space, okay.
Its borders are the teres minor above, the teres major below, and the long head of triceps on its lateral side. Notice, the humerus is not part of this space.
And what runs through this medial triangle?
The triangular space carries a single vessel, the circumflex scapular artery.
To repeat, rule of two, the triangular space is bordered by teres minor above, teres major below, long head of triceps lateral. Its sole content is the circumflex scapular artery. What about the third space?
The third space drops down lower on the arm, below the teres major. It's called the triangular interval.
Triangular interval.
Its borders are the teres major acting as the roof above, the long head of the triceps forming the medial wall, and the humerus forming the lateral wall. Notice the teres minor is entirely out of the picture here.
And what travels down through this lower interval?
The radial nerve and the profunda brachii artery. They use this interval to spiral down the back of the arm.
Repeating the triangular interval. Bordered by teres major above, long head of triceps medial, humerus lateral. Contents are the radial nerve and the profunda brachii artery.
Excellent.
We have our three spaces mapped. But let's zero back in on the money space, the quadrangular space. Why is the axillary nerve running through it such a high-yield topic?
Because the axillary nerve is highly, highly vulnerable to trauma.
In what way?
Let's trace its path to understand why. The axillary nerve originates from the posterior cord of the brachial plexus, primarily carrying C5 and C6 fibers. It starts deep in the armpit, running down the front of the subscapularis muscle.
Okay, in the front.
But its target muscles are on the outside and back of the shoulder, so it has to find a doorway to get there.
And that doorway is the quadrangular space.
Exactly. It dives backward through the quadrangular space. Right. As soon as it exits the space, it wraps tightly around the surgical neck of the humerus, sitting directly against the bone, just millimeters below the shoulder joint capsule.
It's supplying the massive deltoid muscle, which gives the shoulder its round shape and lifts the arm in abduction, and the teres minor, which helps with external rotation. So why is wrapping around the surgical neck so dangerous?
Because it places the nerve squarely in the blast zone of mechanical trauma. If a patient suffers an anterior shoulder dislocation, which is the most common type, where the ball of the humerus forcefully pops out of the front of the socket, the humeral head plunges forward and downward.
Oh, I see.
As it displaces, it severely stretches or even crushes the axillary nerve against the tight fascial bands of the quadrangular space.
And what if an elderly patient falls and suffers a proximal humerus fracture right at the surgical neck?
The sharp, jagged ends of the broken bone can lacerate or impale the nerve directly. But it's not just blunt trauma we worry about. It's an iatrogenic injury. Surgeons are constantly threatening this nerve.
Walk us through that. How does a surgeon accidentally hit a nerve on the back of the shoulder?
The danger is highest during anterior shoulder reconstructions, specifically a letargette procedure.
A letargette.
In a letargette, we are trying to fix a shoulder that keeps dislocating. We take a piece of bone from the front of the shoulder blade, the coracoid process, pass it through a split in the subscapularis muscle, and screw it to the front of the shoulder socket to create a bony block.
Okay, so you're working entirely on the front of the joint.
We are, but remember where the axillary nerve starts before it dives backward? It runs right across the inferior border of the subscapularis.
Oh, right.
When the surgeon places retractors at the bottom of the joint to see what you're doing, the tip of that metal retractor can press directly against the axillary nerve, stretching it into a neuropraxia, a temporary short circuit.
So whether it's a dislocation, a fracture, or a retractor during a letargette, the axillary nerve gets knocked out. How does the patient present in the clinic? What's the signature?
The primary visual signature is wasting of the deltoid muscle. The shoulder loses its rounded contour and looks squared off. Functionally, they will have profound weakness in abduction. They struggle to lift their arm out to the side.
But other muscles, like the supraspinatus we discussed earlier, they also do abduction. What is the specific physical exam finding to prove it's the deltoid and the axillary nerve?
You isolate the deltoid mechanically. The clinical discriminator is that this weakness in abduction is worst when the patient's arm is internally rotated.
Internally rotated.
Yes. In internal rotation, the other abductors are at a biomechanical disadvantage, forcing the deltoid to do all the work. If the deltoid is dead, the arm simply won't lift.
Wow.
Additionally, they will often have a patch of numbness over the lateral aspect of the upper arm. It's the area covered by the badge on a military uniform, known as the regimental badge area.
Okay, so if the axillary nerve is prominently destroyed, maybe severed by a fracture, a patient loses their deltoid. That's a devastating loss of function for the arm. What is the surgical salvage procedure? How do you rewire it?
The modern reconstructive option is a nerve transfer. We use a highly specific procedure called the Leach-Van-Vong's transfer.
Leach-Van-Vong's transfer. Explain the physical mechanics of a nerve transfer. You aren't fixing the crushed nerve, right?
No, the original proximal nerve is dead. You have a paralyzed deltoid muscle that is desperate for an electrical signal and a crushed axillary nerve that can't deliver it. So you steal power from a nearby healthy circuit.
Which one?
In the Leach-Van-Vong's transfer, the surgeon isolates a branch of the radial nerve that normally travels down the back of the arm to supply the medial head of the triceps muscle.
But the triceps has multiple heads, so sacrificing one won't completely destroy the patient's ability to straighten their elbow.
Exactly. You borrow one wire. The surgeon cuts that triceps branch of the radial nerve, swings the live end over, and stitches it directly into the distal stump of the axillary nerve downstream of the crush injury.
That is incredible. So the electrical signal travels down the radial nerve, hits the surgical junction, and flows into the axillary nerve bed to fire the deltoid.
Exactly.
But wait, how does the brain know what to do? When the patient tries to lift their arm, their brain is technically sending a fire the triceps signal.
That's the magic of neuroplasticity.
Oh, right.
Initially, the patient has to consciously think about straightening their elbow against resistance in order to lift their shoulder. But over months of intense physical therapy, the motor cortex in the brain physically rewires its map.
It learns the new pathway.
Yes, it learns that this specific neural pathway now controls the shoulder, not the elbow.
Yeah.
It becomes a subconscious, natural movement again.
A radial nerve branch to the medial head of the triceps transferred to the axillary nerve to power the deltoid. That is phenomenal biomechanical engineering.
It's an elegant solution to a devastating problem.
Okay, here we go. If you only remember one thing from this section, the quadrangular space carries the axillary nerve and the posterior humeral circumflex artery. The axillary nerve supplies the deltoid and teres minor. It is highly vulnerable in anterior dislocations and Latarjet surgeries, and a permanent injury can be salvaged with a Lichtenbong's radial to axillary nerve transfer.
Spot on. Let's shift our focus now from hidden nerve pathology to the most dramatic, visible signature of neuromuscular failure in the shoulder.
Which is?
Scapular winging.
Oh, yes. When you see scapular winging, the shoulder blade literally pops off the rib cage. It looks alien.
It's very striking.
And our entire diagnostic job here is to sort the winging by its geographic direction, right? Medial versus lateral, because the direction tells you exactly which nerve is broken.
Precisely. Medial winging and lateral winging are caused by entirely different mechanisms, involving different muscles and different surgical histories.
Let's unpack medial winging first, because this is the one you see most often. What does it actually look like mechanically?
In medial winging, the medial border of the scapula, the edge closest to the spine, and particularly the inferior angle at the very bottom, it prominently lifts away from the chest wall and rotates inward toward the midline of the back.
Why does it pop backward like that? What stabilizing force has been lost?
The muscle that has failed is the serratus anterior. It is a broad, fan-shaped muscle that originates on the ribs and wraps backward to attach to the underside of the medial border of the scapula.
Like a hammock for the scapula.
Yeah, and its primary biomechanical job is protraction. It pulls the scapula tight against the curve of the rib cage and slides it forward. When the serratus anterior is paralyzed, it acts like a snapped bungee cord.
Ah, I see.
The scapula springs backward, entirely untethered from the ribs.
And the nerve that supplies this bungee cord?
The serratus anterior is innervated exclusively by the long thoracic nerve. This nerve is formed by roots C5, C6, and C7 of the brachial plexus.
Let me repeat the structural pairing. Medial winging is caused by a paralyzed serratus anterior muscle, which is supplied by the long thoracic nerve, roots C5, C6, C7.
Yes.
How do we test for this in a clinic? Because if a patient is just resting, it might not be obvious.
You have to force the serratus anterior to work under load. The classic provocative test is the wall push-up.
The wall push-up.
You ask the patient to stand facing a wall, place their hands flat against it at shoulder height, and perform a push-up.
What forces are at play there?
As they push their body weight away from the wall, the force travels up their arms and tries to drive the scapula violently backward. A healthy serratus anterior fires massively to lock the scapula against the ribs to resist that force.
But if the nerve is dead?
If the long thoracic nerve is dead, the muscle fails under the load. The moment they push, the inferior angle of the scapula will dramatically pop out medially. Elevating the arm in forward flexion will also exacerbate the winging.
So why does the long thoracic nerve fail? We know the axillary nerve is vulnerable to dislocations, but the long thoracic nerve is nowhere near the shoulder joint itself.
It's an anatomical victim of its own long, exposed path. As the name implies, it is a long nerve. Once it leaves the neck, it runs superficially straight down the lateral chest wall, running right on top the outer surface of the serratus anterior muscle it is applying.
That seems like a design flaw. Most motor nerves enter the deep protected underside of a muscle.
It is a remarkable vulnerability. Because it lies completely exposed in the fatty tissue of the armpit, it is at extreme risk during any axillary surgery.
Like what kind of surgery?
The classic textbook scenario is a patient who has undergone an axillary lymph node dissection for breast cancer.
Ah.
The surgeon is meticulously clearing out the lymph nodes in the armpit, and the long thoracic nerve, buried in that fatty tissue, it can easily be bruised, stretched by retractors, or inadvertently cut.
Another scenario mentioned is a transaxillary resection of the first rib for thoracic outlet syndrome, right?
Yes, exactly. Navigating through the armpit to cut out a rib puts that nerve directly in the surgical crosshairs.
Okay, so that is the medial winging profile. Let's repeat it. Long thoracic nerve, serratus anterior wall push-up, axillary surgery.
Correct.
Let's look at the mirror image. What is lateral winging?
Visually, lateral winging presents as the entire scapula translating outward, away from the spine, while also drooping downward.
So it doesn't pop backward?
No, the medial border doesn't violently pop off the ribs like a wing. Instead, the whole bone slides laterally and inferiorly.
What muscle has died to cause that structural slide?
The failed muscle here is the trapezius. It's that massive diamond-shaped muscle covering your upper back and neck.
And what does it normally do for the scapula?
Its primary mechanical role regarding the scapula is elevation and retraction. It pulls the shoulder blade up and pulls it in toward the spine. When the trapezius is paralyzed, gravity pulls the scapula down, and the unopposed surrounding muscles pull it out laterally.
And what nerve powers this massive muscle?
The trapezius is unique. It does not powered by the brachial plexus. It is supplied by a cranial nerve descending from the skull. The spinal accessory nerve, also known as cranial nerve XS.
Cranial nerve S. Let me state that pairing to lock it in. Lateral winging is caused by a paralyzed trapezius muscle, which is supplied by the spinal accessory nerve, cranial nerve XS.
Come on.
Now, we used a wall push-up for medial winging. What's the provocative test for lateral winging?
Because the trapezius is heavily involved in lifting the arm out to the side, lateral winging is dramatically exacerbated by having the patient attempt to abduct their arm against resistance.
Ah, abduction.
Right. The scapula will uncontrollably slide outward.
And what is the surgical trap here?
Yeah.
Because cranial nerve XS isn't in the armpit. Where does it get cut?
Its danger zone is entirely in the neck. After exiting the skull, the spinal accessory nerve takes a very superficial, unprotected course obliquely across the posterior triangle of the neck before it enters the trapezius.
It's practically right under the skin.
Exactly. So the classic exam vignette for a lateral winging patient is someone who recently had a seemingly minor surgical procedure in their neck, most commonly a lymph node biopsy in the posterior triangle.
And the surgeon just nicks it.
The surgeon makes a small incision, excises a node, and inadvertently nicks that superficial nerve. The patient wakes up with a profound trapezius palsy, a drooping shoulder, and lateral winging.
Wow. If that nerve is permanently severed and can't be repaired, what do you do? Earlier we talked about stealing a radial nerve branch for the deltoid. How do you salvage a dead trapezius? It's too big to just ignore.
You're right, the functional loss is severe. The patient will have intractable aching pain in their neck and shoulder from the dead weight of the arm dragging down.
It sounds miserable.
It is. Because the trapezius is so large, a simple nerve transfer often isn't enough. The reconstructive option is a massive biomechanical muscle transfer called the Eden-Lange procedure.
Eden-Lange. How does that work mechanically? What are we moving?
The surgeon has to recreate the upward and inward pull of the trapezius. To do this, they harvest two other muscles that attach to the scapula, the levator scapulae and the rhomboids.
Okay, levator scapulae and rhomboids.
They surgically detach these muscles from their normal insertion points on the medial edge of the scapula, and they transfer them further laterally, reattaching them toward the center of the shoulder blade. By changing their mechanical leverage point, these muscles can now act as a substitute to elevate and retract the scapula, mimicking the lost trapezius.
That's incredibly clever. Now let's take a slight detour because I want to bring up a specific trap you see a lot when studying axillary nerve injuries.
Okay, what's the trap?
We established that the long thoracic nerve in the armpit gets cut during a lymph node dissection, causing medial winging. But there's another major nerve that runs right through that exact same armpit space, right? The thoracodorsal nerve.
Yes. This is one of the most brilliant and recurring traps in anatomical testing. Yes, the thoracodorsal nerve courses directly through the axilla to supply the massive latissimus dorsi muscle on your back.
So it's right in the crosshairs, too.
And yes, because it is in the axilla, it is absolutely at risk of being cut during a lymph node dissection.
So if the surgeon accidentally cuts the thoracodorsal nerve instead of the long thoracic, do you get a third weird type of scapular winging?
Emphatically no. That is the trap.
No winging at all.
The latissimus dorsi is a powerful extensor and adductor of the arm. It pulls your humerus down and tightly into your side. It is the muscle you use to do a pull-up or swim butterfly. Because the latissimus dorsi attaches to the humerus, not primarily to the scapula, cutting the thoracodorsal nerves does not destabilize the shoulder blade.
So the scapula stays flat against the ribs.
Exactly. If the thoracodorsal nerve is cut, you do not get scapular winging. You get weak shoulder reduction and extension. The patient will complain they have trouble pushing themselves up out of a chair using armrests or pulling heavy doors open.
I'm going to repeat this trap to shut the door on it permanently. Listen closely. Scapular winging is only irregularly caused by the long thoracic nerve or the spinal accessory nerve. Thoracodorsal nerve injury equals weak adduction and extension, not winging.
Perfect. Now, we've covered medial and lateral winging. Both of those are almost always unilateral, affecting one side, and they're almost always caused by a specific trauma or surgical complication.
Right.
But what happens when a patient walks into your clinic with bilateral winging? Both shoulder blades are popping off their ribs, and the patient is young, in their teens or 20s, with zero history of trauma or surgery.
If it's bilateral and atraumatic, we can't be looking at localized nerve cuts. We have to be looking at a systemic issue.
Precisely. You must shift your diagnostic mindset away from peripheral nerve injury and toward a systemic muscle disease. The primary suspect for bilateral atraumatic winging in a young person is fascioscapulohumeral dystrophy, or FSHD.
Fascioscapulohumeral dystrophy, FFHD. Let's break that word down anatomically.
The name is essentially a map of the disease. Fascio refers to the face, scapula refers to the shoulder blades, humeral refers to the upper arms. It is an autosomal dominant muscular dystrophy that selectively destroys those specific muscle groups.
What are the key diagnostic markers we're looking for in a patient vignette?
Aside from the severe bilateral scapular winging and the weakness in their upper arms, you must look for the facial weakness. This is the absolute clinical discriminator.
Facial weakness.
The classic tell is that the patient cannot pucker their lips to whistle, or they sleep with their eyes slightly open because the facial muscles are too weak to forcefully close their eyelids.
Oh, wow.
Functionally, their shoulders are devastated. Because the scapular platform is entirely unstable, they cannot generate the leverage to lift their arms above their head.
And because this is a progressive muscular dystrophy, you aren't dealing with a cut nerve that you can transfer or wire back together. The muscles themselves are deteriorating.
Right.
What is the surgical endgame if they are profoundly disabled, unable to even lift their arm to brush their hair or feed themselves?
The treatment of last resort for disabling FSHD shoulder weakness is a radical biomechanical alteration, a scapulothoracic fusion.
A fusion? What does that actually entail in the operating room?
The surgeon exposes the undersurface of the scapula and the corresponding ribs. They strip away the intervening muscle and periosteum, and they physically bolt the scapula directly to the rib cage using heavy plates, screws, and bone graft.
They permanently fuse the bones together.
Yes. You sacrifice mobility for stability. It sounds extreme, but once the scapula is rigidly bolted to the ribs, the deltoid muscle finally has a rock-solid base to pull against.
Giving them back that leverage.
Exactly. This surgery can dramatically restore a patient's ability to elevate their arm in front of them, giving them back basic functional independence.
That is a fascinating trade-off. Bolting the floating scaffold down so the arm can work again. Listen up, if you only remember one thing from this segment. Medial winging equals the long thoracic nerve and serratus anterior, and it's worse on a wall push-up. Lateral winging equals the spinal accessory nerve and trapezius, and it's worse on arm abduction. Bilateral atraumatic winging with facial weakness equals FSHD.
An excellent synthesis.
All right, let's take our first pause to consolidate. This is our mid-session checkpoint to respect your cognitive load before we move into the joints. We are going to quickly trade off the key pairs we've built.
Let's do it.
I'll throw out the anatomy, you hit me with the discriminator. Ready? Suprascapular nerve localizations.
A proximal notch lesion takes out both the supraspinatus and infraspinatus. A distal sphenoglenoid lesion spares the supraspinatus, knocks out the infraspinatus only, and you must look for a SLAP-related ganglion cyst.
The borders and contents of the quadrangular space.
Borders. Teres minor above, teres major below, long-headed triceps medial, humerus lateral. Contents, axillary nerve, and the posterior humeral circumflex artery.
And the scapular winging triplet.
Medial winging.
Yeah.
Long thoracic nerve, lateral winging, spinal accessory nerve, bilateral winging.
Yeah.
Fascioscapulohumeral dystrophy.
Checkpoint clear. Excellent. Now we are shifting our focus entirely.
Moving on.
We spent a lot of time talking about the floating scapula, the nerves that run it, and the spaces around it. But how does this entire floating apparatus physically anchor to the rest of the skeleton? It all comes down to a single strut of bone, the collarbone or clavicle.
The clavicle is the only true bony strut connecting the arm to the axial skeleton, and it accomplishes this through two very distinct joints on either end, Let's start on the outside, the lateral end of the collarbone where it meets the shoulder blade.
Right.
This is the acromioclavicular, or AC, joint.
Mechanically, the AC joint is fascinating. I mean, when you look at an anatomical model, the end of the clavicle just sort of rests against the acromion of the scapula.
It doesn't look very secure.
Not at all. It's not a deep ball and socket joint like the hip. It looks like it should slide right off.
Exactly. The bony architecture provides almost zero inherent stability. The joint relies entirely on two distinct sets of ligaments acting as biological seatbelts to maintain its position.
Two sets of ligaments.
To understand how they fail and how we fix them, we have to divide them based on planes of motion. Let's use a geometric analogy.
I always find an X and Y axis analogy works best here.
Perfect. Let's use that.
Yeah.
The AC joint can dislocate in two primary directions under trauma. The clavicle can slide front to back, or it can pop straight up. The body evolved two specialized sets of ligaments to divide this workload. Let's analyze the x-axis first, the horizontal plane.
What stops the clavicle from sliding anteriorly or posteriorly relative to the acromion?
Horizontal antero-posterior translation is resisted by the acromioclavicular ligaments. These are thickened, tight bands woven directly into the capsule surrounding the joint itself.
AC ligaments for the AC joint.
Right. They sit right across the top, bottom, front, and back of the joint line. Their sole job is to keep the bones aligned front to back.
So, AC ligaments equal horizontal stability. Let's repeat that. AC ligaments resist horizontal translation. What about the y-axis? The vertical plane.
What stops the clavicle from popping straight upward, tearing through the skin, when a massive downward force hits the shoulder? That immense vertical load is handled by the acromioclavicular, or CC ligaments.
CC ligaments.
These are massive, incredibly strong, rope-like ligaments. And critically, they don't even attach to the acromion.
Where do they run?
They run from the coracoid process, a thick, bony hook projecting from the front of the scapula straight, vertically up to anchor into the underside of the clavicle. They literally tie the collarbone down, acting as suspenders against vertical displacement.
Let me repeat the mechanical divide to lock it in. The AC ligaments resist horizontal antero-posterior translation. The CC ligaments, the coracoid ligaments, resist vertical superior displacement.
That is correct. But the exam inevitably goes one layer deeper on those CC ligaments.
Right.
There isn't just one massive band. The coracoid complex is composed of two distinct ligaments.
Ah, of course there are two.
Always. You have the conoid ligament and the trapezoid ligament.
The names give away their shapes, right? The conoid is shaped like a cone, twisting on itself, and the trapezoid is a broad quadrilateral. How are they positioned?
The conoid ligament is situated more medially, closer to the base of the coracoid hook. The trapezoid ligament is positioned lateral to it. And the absolute crucial, highly tested discriminator you must know is their relative strength.
Okay, what is it?
The conoid ligament is the stronger of the two ligaments in resisting vertical displacement.
Let's state that twice. The conoid ligament is the stronger of the two CC ligaments resisting vertical displacement. Again, the conoid ligament is stronger.
So what happens when this complex ligamentous system is overwhelmed by mechanical force? This is the classic shoulder separation. A patient is riding a bicycle, they fly over the handlebars, and they land directly on the lateral point of their shoulder.
Walk through the physics of that impact.
The immense force drives the acromion and the entire scapula violently downward toward the floor. But the clavicle, trapped by the muscles of the neck, wants to stay up.
So they tear apart.
This opposing force shears the ligaments. First, the horizontal AC ligaments snap. If the force continues, the massive vertical CC ligaments stretch and rupture.
We grade these injuries from type 1 to type 6, but clinically and for the exam, it really boils down to knowing when to keep the patient in a sling and when to wheel them into the operating room.
Low-grade injuries, types 1, 2, and 3, are almost universally managed non-operatively. The ligaments might be sprained or the clavicle might be slightly elevated, but the thick fascial envelope of muscle overlying the joint is relatively intact, providing some dynamic stability. We use a sling for comfort and start aggressive physical therapy.
But what are the surgical triggers? When is it bad enough to operate? What defines a type 4 or a type 5 separation?
Types 4 and 5 represent severe, deforming anatomical displacements where the clavicle is utterly detached from its soft tissue restraints.
Okay, what's a type 4?
In a type 4 separation, the clavicle doesn't just pop up. The force drives it violently backward. It punches entirely through the thick trapezius muscle behind it and gets buttonholed there. It is physically stuck in the muscle belly.
A type 4 is buttonholed posteriorly. Let's repeat that. Type 4 is buttonholed posteriorly. What about a type 5?
In a type 5, the clavicle is driven straight up, elevated over 100% of its normal anatomical height. It looks like a tent pole pushing up under the skin.
Oh, that sounds awful.
And the critical surgical discriminator here is that the deltotrapezial fascia, the thick, continuous sheet of muscle and connective tissue that normally covers the clavicle, has been violently, completely detached and stripped away from the bone.
So type 4 is buttonholed backward into the trapezius. Type 5 is stripped of its fascial envelope and displaced sky high. Both of those scenarios demand surgery. How do we mechanically fix that?
Well, in acute, fresh injuries, we often use arthroscopic suspensory devices. We drill a small hole through the clavicle and the coracoid, pass a heavy-duty suture through, and flip little metal buttons on either end to winch the clavicle back down into position while the ligaments heal.
And for older injuries?
For chronic, painful separations that haven't healed, we do a formal CC reconstruction. Historically, this was the Weaver-Dunn procedure where we detached a ligament from the acromion and moved it over. But today, we typically use an anatomical reconstruction, taking a tendon graft from a cadaver and weaving it here to figure 8 between the coracoid and clavicle to physically rebuild that conoid and trapezoid anatomy.
Okay, that covers acute, high-velocity trauma. But the AC joint is also notoriously prone to chronic repetitive wear and tear, isn't it? Let's talk about distal clavicle osteolysis.
Ah, yes. The classic clinical vignette for distal clavicle osteolysis is the heavy weightlifter. You have a patient who has been bench pressing massive amounts of weight or doing heavy overhead military presses for years.
What is physically happening to the bone under that load?
Every time they push that bar up, massive shear stress is transmitted directly through the tiny AC joint. Over time, this repetitive microtrauma overwhelms the bone's ability to heal itself. You get microscopic stress fractures in the distal end of the clavicle.
And then what?
Eventually, the bone simply gives up. It starts to dissolve and resort. On an X-ray, the end of the collarbone looks moth-eaten and cystic. It is exquisitely painful when they cross their arm over their chest.
So they have intense pain, they've tried rest, they've had cortisone injections, and nothing works. The bone is literally dissolving. What is the surgical treatment?
The definitive treatment is a distal clavicle excision. The surgeon physically cuts off the outer centimeter of the dissolving collarbone, widening the joint space so that the rough, cystic bone stops grinding painfully against the acromion.
And this brings us to a hyper-specific exam discriminator. You can perform this bone resection in 2 ways, right?
Open surgery, making a long incision over the top of the shoulder, or arthroscopically, using tiny poke holes and a camera from underneath.
And the exam wants us to know the exact nuanced differences in the outcomes.
They do. They want you to distinguish what arthroscopy is better for and what it achieves exactly the same results in.
Okay, give us the breakdown.
Arthroscopic surgery definitively wins on early recovery metrics. Because you aren't slicing through the thick muscle envelope, patients have an earlier return to activity, fewer wound complications, and less immediate postoperative pain.
Any other benefits to the camera?
Crucially, arthroscopy also allows the surgeon to look inside the main glenohumeral joint to check for SLAP tears or rotator cuff issues while they are there.
Okay, so that's the advantage. But what is equal?
This is the trick.
Yeah.
Both open and arthroscopic techniques resect the exact same amount of bone. And more importantly, long-term studies show both techniques provide the exact same degree of permanent pain relief.
What about the ligaments during the approach? Does the camera save them?
Yes and no. An open excision coming from the top typically sacrifices the superior AC ligament to gain access to the bone. An arthroscopic approach coming from underneath the joint preserves the superior AC ligament, but inevitably sacrifices the inferior AC ligament.
Let me state the discriminator clearly. Let's say it twice. Arthroscopic excision wins on recovery speed and the ability to assess the main joint. But both open and arthroscopic approaches resect the same amount of bone and give the same long-term pain relief. Arthroscopic preserves superior AC, sacrifices inferior.
Exactly.
All right, if you only remember one thing from this segment, AC ligaments resist horizontal translation, while CC ligaments resist vertical displacement, with the conoid being the strongest. Types 4 and 5 separations, defined by backward buttonholing or stripped fascia, demand surgery.
Great. Let's travel along the collarbone to the medial end, where it anchors to the chest. This is the sternoclavicular, or SC, joint.
I'll be honest, studying the SC joint always feels entirely different. Like, the AC joint feels like a sports medicine issue, a cyclist falling, a weightlifter's sore shoulder.
Right, very mechanical.
But the SC joint, It feels like a trauma bay emergency where the tone of the room changes instantly.
That intuition is correct. The anatomical stakes at the SC joint are incredibly high. The direction in which this joint dislocates is literally a matter of life and death.
Let's lay out the mechanics of the injury first. It takes a massive amount of force to pop the SC joint out, doesn't it?
It does. SC dislocations are almost always the result of indirect, high-velocity trauma. Picture a rugby player being tackled aggressively onto their lateral shoulder, or a patient in a high-speed motor vehicle collision where the force slams into the side of their arm.
So the force hits the outside of the shoulder.
And the clavicle acts like a rigid lever arm, pivoting on the first rib. The force hits the outside, and the inside end of the collarbone pops out.
And the direction the medial end pops, whether it goes forward or backward, depends entirely on the rotation of the shoulder at the exact millisecond of impact. This is an absolute rule you must memorize.
It is.
Walk us through the biomechanics.
If the shoulder is violently compressed, while pushed into external rotation, meaning the arm is rolled outward, the medial end of the clavicle is levered forward, popping anteriorly. You get an anterior SC dislocation.
Anterior dislocation.
The clavicle head will visibly stick out like a hard lump on the patient's upper chest. This is by far the most common type.
And what if the shoulder is rolled the other way during the crash?
If the shoulder is violently compressed into internal rotation, the medial clavicle is levered backward, popping posteriorly behind the sternum. You get a posterior SC dislocation.
Let's repeat that mechanical rule twice. External rotation of the shoulder at impact causes an anterior SC dislocation. Internal rotation of the shoulder at impact causes a posterior SC dislocation. Let's say it again. External equals anterior. Internal equals posterior.
Perfect. Now, why does an anterior dislocation result in a relatively benign orthopedic consult, while a posterior dislocation makes every surgeon in the emergency room sweat?
This is where we need to paint a vivid, terrifying picture of the anatomy. What is hiding right behind that joint in the danger zone?
Picture the sternum, your breastbone. Right behind it, at the very top where the clavicles attach, is the superior mediastinum. The anatomy, sitting literally millimeters behind that joint capsule, is the most densely packed, vital real estate in the body.
The mediastinum, what's in there?
You have the trachea, the windpipe, you have the esophagus, and crucially, you have the great vessels, the innominate artery, the massive brachiocephalic veins, the superior vena cava, and the branches of the aortic arch.
Oh, wow. So if that clavicle head, which is a thick, solid, dense piece of bone, gets forcefully levered backward into that space.
It acts like a bony battering ram plunging into the mediastinum. A posterior SC dislocation can compress the trachea, causing instant stridorous airway compromise, where the patient is gasping for breath.
That's terrifying.
It can crush the esophagus, making it impossible to swallow. Worst of all, it can compress or tear a great vessel, causing catastrophic internal bleeding. The patient might present with a rapidly expanding hematoma pushing their neck out, or venous engorgement in their arm because the blood can't return to the heart.
It's an absolute vascular and respiratory emergency.
It is. If you diagnose a posterior SC dislocation on a CT scan, you do not just casually pull on the arm in the emergency room to pop it back into place.
Because pulling on it might make it worse.
Exactly. The bony head of the clavicle might currently be acting as a plug, tamponating a hole it just punched in the subclavian vein.
Oh, man. So if you pull it out...
If you pull the bone out of the hole without preparation, the patient can rapidly bleed to death. The reduction must often be done in a fully prepped operating room, with a cardiothoracic surgeon scrubbed and standing by with a sternal saw ready, just in case reducing the bone unleashes a massive hemorrhage.
That is adequately terrifying. Now let's pivot from trauma to planned surgery. Sometimes orthopedic surgeons have to deliberately resect or cut away the medial end of the clavicle, perhaps due to severe, painful arthritis or a chronic bone infection. Our sources highlight a massive, career-altering surgical trap here.
And this trap all comes down to a single anchoring structure, the costoclavicular ligament.
The costoclavicular ligament.
This is a very stout, incredibly strong, short ligament that ties the underside of the medial clavicle straight down to the cartilage of the first rib. It is the primary, indispensable stabilizer of the medial clavicle.
So if a surgeon is cutting away arthritic bone, what is the boundary line they cannot cross?
If you are resecting the medial clavicle, you must keep your bone cuts medial to the costoclavicular ligament.
Medial to the ligament.
You have to leave that ligament firmly attached to the remaining shaft of the clavicle.
What happens if you get greedy? If the arthritis extends pretty far out and you cut the bone lateral to that ligament?
If you cut lateral to the costoclavicular ligament, You have just detached the only anchor holding the collarbone down.
Yeah.
You have completely destabilized the remaining clavicle shaft.
What does that look like for the patient?
It's a disaster. Every time the patient breathes heavily or moves their arm, the sharp, cut end of the collarbone will wildly toggle up and down under the skin, threatening to pierce out and causing severe, intractable pain. The surgery meant to cure their arthritis has just crippled their shoulder mechanics.
Let me state the resection trap clearly to lock it in. We'll say it twice. When resecting the medial clavicle, you must preserve the costoclavicular ligament to prevent catastrophic destabilization of the clavicle. Keep the resection medial to the ligament. One more time. Preserve the costoclavicular ligament. Keep it medial.
That is an unbreakable surgical rule.
If you only remember one thing from this segment, anterior SC dislocation follows external rotation. Posterior SC dislocation follows internal rotation and is an acute medical emergency threatening the great vessels of the mediastinum. And always preserve the costoclavicular ligament during medial clavicle resections.
Which brings us to our second consolidation checkpoint. Let's synthesize the clavicle mechanics we just covered.
Sounds good. All prompt. You provide the discriminator. AC versus CC ligaments in the shoulder separation.
AC ligaments resist horizontal translation. CC ligaments resist vertical displacement.
Which is the strongest CC ligament?
The conoid ligament.
What defines the types 4 and 5 AC separations that require surgery?
Type 4 is buttonholed posteriorly through the trapezius. Type 5 is stripped of the deltotrapezial fascia and elevated over 100%.
SC dislocation mechanics.
External rotation equals anterior dislocation. Internal rotation equals posterior dislocation, which threatens the mediastinum.
And the resection rule for the medial clavicle.
Always preserve the costoclavicular ligament.
Second checkpoint clear. We are entering our final major segment, and this is where the diagnostic waters get truly muddy. Segment 6, neurovascular syndromes.
This is a tough section.
It really is. Up until now, we've talked about mechanical injuries, high-velocity trauma causing dislocations, fractures crushing nerves, cysts pressing on tissues. But sometimes a patient presents with acute, baffling pain or weakness, and there is absolutely no mechanical trauma involved.
These are the phantoms of shoulder pathology. The syndromes where the hardware, the bones, the ligaments, the tendons looks perfectly fine on imaging, but the software running the arm is catastrophically crashing.
Let's start with a classic, highly tested presentation. A patient walks into the clinic. They report experiencing acute, severe 10 out of 10 shoulder pain that started randomly in the middle of the night.
Okay.
They didn't fall. They didn't lift anything heavy at the gym. They might mention they had a mild cold or a viral stomach bug or maybe a vaccine for a week or two. Then, just as the pain finally starts to fade, they realize they can't lift their arm. They have profound, sudden weakness, commonly in the serratus anterior, the deltoid, or the spinati muscles. You get x-rays, totally normal. You get a high-resolution MRI, completely pristine, no tears, no cysts. What is happening?
You are describing the textbook clinical cascade of brachial neuritis, which is historically also known as Parsonage-Turner syndrome or neuralgic amyotrophy.
Parsonage-Turner syndrome. So if the MRI shows no structural compression, no disc pressing on a nerve in the neck, what is actually causing the pain and the weakness?
It is an immunological firestorm. We believe brachial neuritis is an autoimmune inflammatory response. The body's immune system, often triggered by a recent viral infection or an environmental stressor, mistakenly identifies the brachial plexus, the complex network of nerves supplying the arm, as a foreign threat.
It starts attacking its own wiring.
Exactly. The initial phase is acute, raging inflammation of the nerves, which generates that horrific, unremitting pain. That's the inflammatory phase. As the attack continues, it causes physical axonal damage. It strips the insulation and damages the core wires of the nerves.
And when the wires are damaged, the electrical signal stops.
That's why the profound weakness and muscle wasting set in just as the painful inflammatory phase burns itself out.
So how do you definitively prove this diagnosis if the MRI is clean? You can't just guess it's autoimmune.
It is fundamentally a diagnosis of exclusion. You must first rule out a structural cervical spine issue, like a herniated disc or a massive rotator cuff tear. Once structural causes are eliminated, the confirmatory test is an EMG electromyography.
Sticking needles into the muscles to listen to the electrical activity.
Yes. In brachial neuritis, the EMG will show acute denervation changes in the affected muscles. It proves the muscle is starved of electrical input, confirming the nerve injury, even without a structural compression visible on a scan.
We'll have to repeat this clinical picture twice to lock it in. Severe atraumatic shoulder pain, often post-viral, followed a week later by profound weakness with completely normal x-rays and normal MRIs, is brachial neuritis or Parsonage-Turner syndrome. The diagnosis is confirmed by EMG. Say it with me. Severe pain, then weakness, normal scans equals brachial neuritis.
The silver lining for the patient is that it is usually a self-limiting condition. The nerves do slowly regenerate, but the recovery is notoriously protracted, often taking 12 to 18 months of intensive rehabilitation to regain full function.
Let's pivot from atraumatic autoimmune phantoms to a very specific high-velocity sports trauma scenario, the stinger or burner.
Very common in athletes.
We see this all the time in collision sports like American football, rugby, or wrestling. A player takes a massive awkward hit to the head and shoulder. They jog off the field with their arm hanging dead by their side, shaking their hand, complaining of a terrifying burning electrical shock sensation shooting down their arm.
That is the classic stinger. Anatomically, a stinger is a transient, meaning temporary traction injury to the upper trunk of the brachial plexus, primarily affecting the C5 and C6 nerve roots.
Explain the physics of a traction injury. How does a hit stretch the nerves?
Imagine a rugby tackle where the player's head is violently forced sideways to the right while their left shoulder is simultaneously driven powerfully downward into the turf. The brachial plexus connects the neck to the shoulder. When the head and shoulder are violently driven in opposite directions, it stretches those nerve roots beyond their physiological tensile limit.
Much like snapping a rubber band.
Yes, and that extreme stretch causes the nerve to short circuit. It causes a neuropraxia, a temporary block in nerve conduction without structural severing of the axon.
So the wire isn't cut, just temporarily stunned.
Right. This results in the brief, terrifying deadness of the arm and the intense burning neuropathic pain.
So they have brief weakness and burning on the sideline. But the critical exam question and the critical medical legal question for the team doctor is always about return to play. When can you safely send that athlete back onto the field?
The rules for return to play after a stinger are absolute and rigid. You cannot send them back out until two strict criteria are met. First, their cervical spine, their neck exam, must be completely normal.
Normal neck exam.
They must have full, pain-free range of motion of their neck with no midline bony tenderness. We must ensure there is no hidden cervical fracture or catastrophic spinal cord injury masquerading as a peripheral nerve stretch.
And the second rule?
Second, the neurological deficits in the arm must have completely and fully cleared. The burning sensation must be gone, and their motor strength in the shoulder and arm must be 100% back to their baseline normal.
100% back.
If they have even a subtle hint of lingering weakness in abduction or external rotation, their game is over. Sending them back out with a weakened shoulder complex invites a devastating, permanent nerve avulsion if they get hit again.
Let's state that twice. The neck must be normal, and strength must be 100% back to baseline. Again, normal neck, 100% strength. No exceptions. Okay, let's move to our final neurovascular syndrome, and this is an incredibly complex one. Thoracic outlet syndrome, or TOS.
TOS is a broad umbrella term for the physical compression of the neurovascular bundle, meaning the brachial plexus nerves, the subclavian artery, or the subclavian vein, as they exit the narrow anatomical bottleneck between the base of the neck and the chest, known as the thoracic outlet.
Let's hit the key statistics right away, because the exam loves to test the prevalence of what is actually getting compressed. You have 3 potential victims in that bottleneck: nerves, arteries, or veins. What is the breakdown?
The vast, overwhelming majority of thoracic outlet syndrome is neurogenic, meaning it is compression of the brachial plexus nerves. Specifically, about 95% of all clinical TOS cases are neurogenic.
95% neurogenic. Let's repeat that. 95% of TOS is neurogenic.
Only a tiny fraction, around 5%, involve compression of the subclavian vein or artery.
And because it's almost entirely nerve compression, what is the most common presenting symptom the patient complains of?
Pain. A vague, aching, intractable pain in the neck, shoulder, down the arm, or into the hand, frequently accompanied by paresthesia's numbness or tingling in the fingers.
And what triggers it?
Classically, these symptoms are heavily exacerbated by overhead activities, like painting a ceiling or washing their hair, which mechanically narrows that thoracic outlet even further.
Now, when we talk about what is physically causing the compression in that bottleneck, we always hear about cervical ribs, an anomalous extra rib growing out of the cervical spine above the normal first rib.
Cervical ribs are the classic textbook cause, but here are the statistical realities you must know for the exam. A cervical rib is actually quite a rare anatomical anomaly. It is present in less than 1% of the general population.
Okay, less than 1% of people have them.
And here's the fascinating, highly tested quirk regarding cervical ribs. Even though about 70% of people who possess a cervical rib have them on both sides of their neck bilaterally, the clinical symptoms of thoracic outlet syndrome are usually only unilateral, affecting just one arm.
That's a great nuance to lock away. 70% of cervical ribs are bilateral, but the clinical symptoms are usually unilateral. Twice for that stat, 70% bilateral anatomy, unilateral symptoms.
Now, to truly understand the mechanics of TOS and to nail the complex anatomy questions on the exam, we have to mentally construct the floor of the thoracic outlet. We have to verbally map the anatomy of the first rib.
I was hoping you'd say that. I'm challenging you right now to paint the 3D layout of the first rib purely with your words. No pictures. Where do the veins, arteries, and muscles sit in relation to each other?
Challenge accepted. Visualize the top surface of the first rib. It's a flat, broad, curved piece of bone forming the top of the rib cage. Right in the middle of the upper surface of that curve, there's a small, distinct, bony bump. That bump is the scalene tubercle.
The scalene tubercle. It is our central anchoring landmark for the whole region.
Attaching directly to that bony tubercle is a muscle descending from the neck called the scalenus anterior. Imagine this muscle acting like a partition, a solid vertical wall that divides the surface of the rib into a front half and a back half.
Okay, we have a wall in the middle of the rib. Let's look at the front valley. What is anterior to the wall?
Anterior to the scalenus anterior muscle, carved into the bone, there is a shallow groove. Running directly through that groove is the massive subclavian vein.
Subclavian vein in front.
Also on the anterior aspect of the rib, placed even further forward toward the sternum, you have attachments for the subclavius muscle and that critical costoclavicular ligament we discussed earlier.
So vein in the front valley, what is behind the wall?
Posterior to the scalenus anterior muscle, there is a second groove. This one carries the high-pressure subclavian artery, and nestled right next to and slightly behind the artery is the lower trunk of the brachial plexus.
This spatial layout is critical. Let's do a repetition to cement this architecture. On the first rib, the central landmark is the scalenus anterior muscle attaching to the tubercle. Anterior to this muscle is the subclavian vein. Posterior to this muscle is the subclavian artery and the brachial plexus. The muscle physically separates the vein from the artery.
Let me repeat it one more time for absolute unbreakable clarity. Vein anterior, artery posterior, separated by the scalenus anterior muscle.
Are there any other crucial nerves navigating through that immediate area that we need to avoid in surgery?
Yes, two important ones. The upper and middle trunks of the brachial plexus emerge at the lateral edge of the scalenus anterior, slightly higher up. And crucially, the phrenic nerve, which is the singular nerve that controls your diaphragm and allows you to breathe, courses vertically straight down the anterior surface of the scalenus anterior muscle before diving into the chest.
Incredible word painting. I can see the wall, the vein in the front valley, the artery in the back valley, and the phrenic nerve running down the front of the wall. If you only remember one thing from this segment, brachial neuritis presents as severe atraumatic pain followed by weakness with entirely normal scans. And on the first rib, the subclavian vein is anterior, the subclavian artery is posterior, and they are physically separated by the scalenus anterior muscle.
A perfect distillation of a very dense anatomical region.
Which means we have arrived. It is time for the final fast lap, the lightning round recap. We are going to sear these diagnostic signatures into your brain one last time before you walk into the exam hall. I'm going to fire off the clinical prompts, and you're going to give me the exact, concise discriminator. No fluff, just the answer.
I'm ready. Let's go.
Suprascapular nerve. Proximal notch lesion versus distal sphenoglenoid lesion.
Proximal notch lesion knocks out both supraspinatus and infraspinatus. Distal sphenoglenoid lesion, spear supraspinatus, knocks out infraspinatus only.
Spatial relationship of the suprascapular nerve passing the transverse scapular ligament.
Army over, navy under, artery over the ligament, nerve deep under it.
Quadrangular space contents.
Axillary nerve and the posterior humeral circumflex artery.
Medial scapular winging, nerve, muscle, and provocative test.
Long thoracic nerve, serratus anterior muscle, exacerbated by a wall push-up.
Lateral scapular winging, nerve, muscle, and provocative test.
Spinal accessory nerve, trapezius muscle, exacerbated by shoulder abduction.
AC versus CC ligaments. What plane of displacement does each resist?
AC ligaments resist horizontal translation. CC ligaments resist vertical displacement. The conoid is the strongest CC ligament.
Sternoclavicular dislocation. What shoulder rotation causes anterior versus posterior?
External rotation of the shoulder causes an anterior SC dislocation. Internal rotation causes a posterior SC dislocation.
Patient with severe atraumatic shoulder pain, followed by weakness, but a completely pristine MRI diagnosis.
Brachial neuritis, also known as Parsonage-Turner syndrome.
First rib layout. Which vessel is in front of the scalenus anterior muscle and which is behind?
Subclavian vein is in front. Subclavian artery is behind. They are separated by the scalenus anterior.
And breathe. That was phenomenal.
It's an immense volume of information to synthesize.
Yeah.
But when you break it down into these specific mechanical signatures and spatial relationships, it transforms from a wall of text into a solvable puzzle.
It really does. As we synthesize everything we've covered today, I keep going back to that opening concept. The shoulder girdle truly is a complex tensegrity scaffold hung entirely on nerves. We spent this time proving that by mastering the exact signatures of failure, knowing precisely why a wall push-up causes medial winging, or why an internal rotation force threatens the mediastinum, the vast, murky complexity of the shoulder makes perfect mechanical sense. You don't need a clean bone snap on an X-ray if you know how to read the wiring diagram.
That is the essence of orthopedic neurology. But I want to leave you, the listener, with a final provocative thought, a sort of clinical paradox to mull over as you continue your studies and step into the operating theater.
I love a paradox. What is it?
Think about the recurring villains in shoulder pathology that we discussed today. The axillary nerve wrapping, dangerously tight through the quadrangular space. The long thoracic nerve line completely exposed and vulnerable on the chest wall.
Yeah.
These are the fragile wires that fail and cause devastating, life-altering functional loss. Yet these are the very same structures that an orthopedic surgeon constantly, inevitably threatens every time they pick up a scalpel to fix mechanical bones.
Wow, that's true.
When we perform a lauder jet to stabilize a joint, we dance millimeters from the axillary nerve. When we fix a clavicle, we risk the plexus. The paradox of the shoulder is this. Healing the mechanical scaffold almost always risks cutting the delicate wires that control it. The surgery itself is a calculated, terrifying dance on a minefield of nerves.
Healing the scaffold inherently risks cutting the wires. That is a heavy and incredibly true reality of the operating room. Thank you for that perspective. And thank you, the listener, for diving deep into the muddy waters of the shoulder girdle with us today. Next time we are moving down the arm, our next deep dive will tackle the elbow, exploring valgus load-throwing biomechanics, the complex intricacies of the collateral ligaments, and the dreaded posterolateral rotatory instability. It's going to be another dense one. We'll see you there.